Okay, now we will be talking about ortho injuries part 2, which include the ACL injury, ACL tear, and the PCL tear, and collateral collateral ligaments, and the meniscal tear. Talk about stress fracture, talk about tibia fibular fracture, talk about Achilles tendon tear, talk about ankle fracture, strain or sprain. We're gonna talk about compartment syndrome. Okay, let's generate pictures for each one of them, and boom, we have the pictures: ankle fracture, ACL tear, PCL tear, tibia fibular fracture, compartment syndrome, Achilles tendon tear, stress fracture, collateral ligaments, meniscal tear. Let's talk about each one of them. Okay, let's start with an ACL tear. So how does that happen? Actually, force from behind the knee. What that gonna cause? Okay, while the leg locked and extended when hit. Okay, locked and extended, and you hit. That's why when you fight, you always flex your knee so that you decrease the chance of getting tear. But if you're extended, locked, and then you get hit from behind, then you tear the ACL. And it makes sense, right? If you hit it from behind, the anterior will pop up. So how do you diagnose? What's the clinical symptoms? Usually anterior draw sign, and you diagnose it by MRI. And how do you treat it? If it's an athlete, then you do surgical repair. If it's a non-athlete, then you do conservative management. Okay, now let's talk about the PCL tear. PCL tear usually force from the front, in front of the knee, front, while leg locked, extended when hit. Same thing. So basically just front hit. So what symptoms does the patient? So you check with the posterior draw sign, and then you check that with an MRI. That's how you confirm it. Okay, and then the management, if an athlete's surgical repair, surgical, and non-athletes conservative. Okay, so basically same thing, similar to the posterior draw sign. Now, tibia fibular fracture, how does that happen? So tibia is large and strong. Tibia large and strong. So if the tibia fracture occur, fibula usually associated with that, tibia is large and strong. Okay, so how does that usually present? The patient major trauma, either major trauma, adult pedestrian stroke, or purposeful blunt strike to the leg. Okay, or so it's either car strike or just leg strike. Okay, purposefully. Okay, so how do you diagnose that? X-ray usually. If it's closed, then we do casting. If it's open, then we do open reduction internal fixation, and nailing. You did that too. Okay, so this is tibia, fibula fracture. Let's see what else. Ankle fracture, sprain and strain. How do you manage that? Let's see. So it's usually, how does that happen? Usually inversion or eversion of foot. Mechanism, usually it's a sprain. Sprain is same thing as strain, same thing as a fracture, like for the ankle. So usually inversion or eversion of foot, excessive, of course. How does that patient present? Swollen, tender, painful ankle. How do you usually diagnose that? X-ray to rule out fracture. Okay, and then you do, if there's sprain or strain, then you do, okay, so if it's a sprain or a strain, what do you do that? Usually rice. You give them rice and crutches. Rice mean rest, ice, compression and elevation. That's what you do that. Okay, but if there is a fracture, then you do open reduction internal fixation or casting. Okay, if the person can walk on the foot, then do not image. If person walk on foot, no image. You don't need to do imaging. Okay, so this is the ankle fracture. Let's see what else we did. No, let's see what else do we have. Meniscal tear. Let's talk about that. What is the meniscal tear? Usually meniscal tear, the pathophysiology they don't know, unknown pathophysiology. But the patient, how does patient present? Usually young, healthy athlete present with knee pain and click on full extension. Knee pain and click on full extension. So how do you, let me see, extension, how do you diagnose that? Usually MRI only if athlete. You do MRI. How do you manage it? If it's athlete, then you do arthroscopic repair. If it's a non-athlete, you just conservative. Okay, so that's the meniscal tear. Now let's see collateral ligaments. Collateral ligaments, usually if it's a valgus, then this is a lateral force and cause medial tear. If it's a varus, then this is due to a medial force and it's a lateral ligament tear. Lateral ligament tear. So how the patient present? Okay, you just look, there's no buzz phrase, you just look for injury type. Football tackle, that's most common. How do you diagnose that? MRI. If it's a one ligament, then you do hinge cast. Okay, if it is multiple ligaments, then you do surgery. Okay, so that's basically collateral ligaments. Okay, now let's talk about stress fracture. Okay, stress fracture usually caused by pushing a weak bone beyond the capacity. Pushing bones beyond capacity. That's what happened. Usually, how does that present? Weakened warrior athletes, okay, or reserve military force march. Okay, look for out of shape and lots of activity. So this is what you look like, patient who work out a lot but now they're out of shape. Okay, so out of shape and lots of activity, which means the patient usually used to be very active, now they're out of shape. And you can also see pinpoint tibial pain. Okay, so what do? You do x-ray. It could be normal on day 1, okay, and there's a fracture on day 7. So this is the presentation of x-ray. This is how we diagnose stress fracture. Initially normal, and then on day 7, that's when we present. That's why you call these scaffold fracture and stress fracture. We do follow-up x-ray to diagnose it. This is very important. How do you manage that? You do cast and crutches even if the x-ray is normal. That's a stress fracture. Now, Achilles tendon tear, let's talk about that a little bit. So Achilles tendon tear is usually, from its name, it's a avulsion of the Achilles tendon. How the patient present? Usually loud pop, followed by limping, and the patient wouldn't be able to plantar flex. Unable to plantar flex. Gap where the Achilles tendon should be. So there's a gap in the place where there's Achilles tendon, like that. There's a gap. Boom, boom, boom. A gap. How do you diagnose that? Usually clinical. How do you treat them? You can do conservative management, which is you casting for months, or you can do surgery for weeks if you do aggressive management. Okay, so this is basically the Achilles tendon fracture. Now the compartment syndrome. What do we have? Usually compartment syndrome is usually perfusion injury on the facial plane that's confined compartment, perfusion injury. So how does that patient present injury? Okay, how does the patient present? Usually tense leg plus pain, excruciating actually pain, excruciating pain. Okay, excruciating pain. So how do you diagnose that? You measure compartment pressure if unsure, and surgery if unsure too. How do you treat that? You just relieve the pressure by doing fasciotomy. Okay, so that's basically the compartment syndrome. Okay, now let's just do a quick recap of whatever thing we talked about. So ankle injury due to inversion or eversion, you do swollen, tender, painful, and you do x-ray. And if it's sprain, you do RICE. If it's fracture, you do ORF. ACL tear, which RICE like rest, ice, compression, elevation, or fracture, open reduction, internal fixation. ACL tear, force from behind, usually MRI, surgical repair of athlete, conservative if not athlete. PCL, force from front, MRI, same thing, surgical if athlete, conservative if not. Tibia, fibula. Tibia is larger and stronger, so any fracture of the tibia, this is fibula included. Usually major strike, car strike on the tibia, or leg strike purposefully. You do x-ray. If it's a closed fracture, casting. If it's an open reduction, internal fixation. Compartment syndrome, usually tense leg and excruciating pain. We treat it with fasciotomy and measure compartment syndrome to diagnose that. Compartment pressure, I mean. Achilles tendon tear, usually loud pop and limping after that. They can't plantar flex. And how do you diagnose that? Clinical, and you just do either casting or surgery to fix that. Stress fracture, usually pushing beyond your capacity. So X-ray on day 1 normal, on day 7 there is a fracture. You cast and crutches, even the X-ray is normal because it doesn't show up on the first day. Collateral ligament, usually if there's a lateral force, that's the medial tear. If there's a medial force, that's the lateral tear. Usually in football tackle, you diagnose it with MRI, and if it's the one ligament, you do hinge cast. If it's multiple ligament, you do surgery. Meniscal tear, they don't know what's causing it, so the young healthy athlete usually and present knee pain and click on full extension, depends with click when they extend. MRI, we do that if an athlete, and we usually arthroscopic repair if an athlete. If non-athlete, conservative. So basically conservative if non-athlete, it's meniscal tear, ACL, PCL. Okay, this is the same management, similar. Open reduction, internal fixation of fracture and tibia, fibula. If there's an ankle fracture, we do the open reduction, internal fixation. Okay, basically that's the thing. Stress fracture, casting. Achilles tendon, casting too. Manage with casting. And ankle fracture, if it's the only sprain, we do rice and crutches. And that's basically summary of the part 2 ortho injuries. Thank you so much for listening.